is a chronic multisystem disease where there's an abnormal insulin production or impaired insulin use. There are two types. Type 1 diabetes is an autoimmune disease. The peak onset by 20 years of age. It is seen in the younger population. It is insulin dependent because the body stops producing insulin altogether because of that autoimmune destruction. It occurs rapidly and acute. The classic signs of type 1 diabetes are going to be the 3 Ps, which are polyuria, frequent urination, polydipsia, excess thirst, and polyphagia, excess hunger. Other symptoms include weight loss, weakness, and fatigue. Type 2 diabetes is a major contributor for heart and renal disease, stroke, and family history. It is more associated with metabolic syndrome, so we see more elevated glucose, obesity, mostly abdominal obesity, hypertension, elevated triglycerides, low density lipoprotein, and decreased high density lipoproteins. Type 2 cannot effectively use the insulin the body produces, but once given that insulin via medication, the body manages as it should. The onset is insidious, unlike type 1, and we see this most in older adults. It is asymptomatic in the early stage, so we don't have the 3 Ps. We may see the classic Ps, type 1, but commonly we see non-specific symptoms such as fatigue, prolonged wound healing, and visual changes. The main component for treating type 1 diabetes is going to be insulin medication, which we will talk about more in detail as later on. Because insulin is insulin dependent, because type 1 is insulin dependent, the main thing we want to focus is giving them that insulin because they can't produce it. As well as self-monitoring blood glucose, you want to make sure they know signs of hypoglycemia and hyperglycemia. And nutritional therapy, what they should eat, what they shouldn't eat. Exercise is very important also to manage it. And all these components all together we're using to treat and make sure there's a better outcome in this type of disease.
Insulin therapy. Insulin is the key to allow glucose into the cell. It is released when glucose levels are high. Insulin deficiency needs are met by administering insulin. It is modified to have different times of action, peak, and duration. Insulin is used for type 1 and type 2 diabetes that is uncontrolled by diet and exercise. Insulin can be administered subcutaneously or IV. Only regular insulin can be given IV, however. Insulin is a clear and colorless solution. However, NPH is a cloudy suspension. Storage of insulin should be stored in refrigerator until needed. Can be kept up to 1 month after opening, and it is important to keep out of direct sunlight. As a nurse, it is important to know the onset, peak, and duration. It is important to understand the symptoms of hypoglycemia and hyperglycemia to prevent an adverse reaction. Not all insulins are compatible, so it is important to understand what insulins can be given at the same time. They are not to be mixed in a single syringe except for NPH and regular insulin. And it is important to remember to draw it up clear to cloudy. First regular insulin and then NPH. It is important to achieve optimal control of glucose. And patient education is very important because ultimately it is up to the patient to remain in control of their glucose levels. Some types of insulin include rapid-acting, short-duration insulin, slower-acting, short-duration insulin, which is the regular insulin. There's intermediate duration and long duration. Examples of short-duration and rapid-acting insulin will be insulin Lispro, Humalog, Aspart, which is Novolog, and glulisine, which is Apidra. The onset is 15 to 30 minutes. It peaks in 30 to 90 minutes and lasts 3 to 6 hours. Regular insulin includes Humulin-R and Novolin-R insulins. The onset is 30 to 60 minutes. It peaks in 1 to 5 hours and lasts 5 to 7 or up to 10 hours. Intermediate acting insulin is the cloudy suspension called NPH. Onset is 1 to 1.5 hours. It peaks in 4 to 12 hours and lasts for 6 to 12 hours. Long duration insulin includes insulin glargine and detamir. Onset is 1 to 2 hours. It has no peak because the duration is 24 hours. Insulin should be given 30 minutes before eating so the insulin can be in effect when the food enters the bloodstream. Site rotation is important with each administration. Common sites include the abdomen, upper thigh, and upper arm. Overall, insulin therapy is very effective in achieving glucose control, but it is ultimately up to the patient to monitor their sugar levels. And now, Jenny will discuss common complications of diabetes.
Complications of diabetes. The first complication I'm going to talk about is diabetic ketoacidosis, or DKA. DKA is characterized by glucose levels that are greater than 250 and occurs when there is a deficiency of insulin and the body makes up for that deficiency by breaking down fat. As a result, you get ketones, a byproduct of fat metabolism. And your body tries to get rid of the accumulation of acid with Kussmaul respirations, a labored breathing pattern that is rapid and deep. An increasing level of ketones in the body causes one's breath to smell like juicy fruit gum, as you can see in the picture here. Dehydration is another symptom of DKA, along with confusion, and left untreated, coma and eventually death can occur. On the other hand, patients with diabetes are also at risk for hypoglycemia, which can result when blood glucose levels drop to less than 70. There are many signs and symptoms associated with hypoglycemia, and I like to use the acronym TIRED to remember these signs and symptoms. The T in TIRED stands for tachycardia, I for irritability, R for restlessness, E, excessive hunger, D, diaphoresis. You can also remember hypoglycemia with the saying, cold and clammy, need some candy. So blood vessels, both large and small, become damaged over time in diabetes, and the narrowing of these blood vessel walls affect blood circulation to various parts of the body. A number of complications can result from these changes. One complication is hypertension. According to the American Diabetes Association, 2 out of 3 people with diabetes report having high blood pressure. Stroke and heart attacks are also complications of diabetes, resulting from plaque buildup or atherosclerosis. Next, neuropathy, or nerve damage, can lead to pain or loss of feeling, especially in the legs. According to the American Diabetes Association, about half of all people with diabetes have some form of nerve damage. This results in foot complications such as ulcers, and when a patient is oblivious to any injuries of the feet, infections can occur due to poor circulation, and this can lead to amputation. Diabetes affects the blood vessels of the kidneys. In time, the stress on the kidneys affects their filtering capabilities, and this can lead to kidney failure. Diabetes also affects the small blood vessels of the eyes and increases the risk of eye complications, such as glaucoma or the formation of cataracts. Left untreated, eye complications can lead to blindness. Lastly, skin conditions. About 2/3 of people with diabetes develop skin problems. Due to poor circulation and the inability of the liver to get rid of all the accumulating waste in the body, patients can experience itchiness of the skin. And people with diabetes are more prone to bacterial and fungal infections of the skin.
Okay, now we're going to talk about nursing interventions for diabetes. The biggest nursing intervention for a patient with diabetes is proper education. It is not uncommon for a diabetic to check his serum glucose about 8 times a day. To make sure their diabetes is under control, they should be also checking their hemoglobin A1C every 3 to 6 months. As far as self-monitoring their glucose levels, their goal should be between 70 and 130 milligrams per deciliter before meals. They should immediately be treated if they become symptomatic for hyperglycemia or hypoglycemia. Hypoglycemia signs and symptoms can occur when their glucose levels drop below 40. Some of these include anxiety, irritability, tremors, diaphoresis, hunger, blurred vision, and headaches. As a nurse, teach the patient the Rule of 15s for a hypoglycemic attack. The patient should drink 15 grams of a quick-acting carb, such as 4 to 6 ounces of orange juice, regular pop, or 8 to 10 lifesavers. You should then wait 15 minutes and recheck the patient's glucose. If their blood glucose is less than 70, you need to repeat the treatment. Check their glucose levels again afterwards. If 2 to 3 attempts of the quick-acting carbs do not work, call 911 and go directly to the hospital. Be sure to check the patient's gag reflex before ingesting anything. For patients that are unconscious with hypoglycemia, a nurse is responsible for hanging an IV of 25 to 50 milliliters of 50% glucose. Hyperglycemia signs and symptoms can occur when the patient's glucose reaches above 126 milligrams per deciliter. As Diana mentioned before, these symptoms can include the 3 Ps: polydipsia, polyuria, polyphagia, and they can also have weakness and fatigue. Dangerous hyperglycemia symptoms may include the Kussmaul respirations, dehydration, and loss of orientation, and sometimes even fruity breath. An important nursing intervention is proper insulin administration. If we can refer back to our skills we were taught in first track, we can remember that we need to check when their last insulin injection was, where the site was, and remember to rotate, when they last ate, when their next meal will be, and we also need to know the peak, onset, and duration of medication. Just some reminders when giving insulin: remember to roll the vial between your palms, double check the insulin amount with another nurse when you draw it back up, use the one-handed technique when capping the needle, and clear before cloudy, mixing with regular insulin with the NPH. Remember when you're giving it to pinch the skin and administer at a 45 or 90 degree angle. As a nurse, you should also educate your patients on subcutaneous injection sites, which include the abdomen, upper thigh, and back of the arm, for example. As far as insulin storage, we need to educate our patients on proper insulin storage. Insulin should be refrigerated until it is needed. It should not be frozen. Make sure to check the date of expiration before giving, and do not leave insulin under sunlight or heat. After opening their insulin, it can be kept up to 1 month without loss of activity. Nutrition is a very important part of managing diabetes. As a nurse, it is important to collaborate with the endocrinologist and the dietitian to make sure they're eating healthy and maintaining their glucose levels at a healthy level. During my med-surg clinical a few weeks ago, I came across a patient with a new diagnosis of type 2 diabetes. I went into his room around 8 a.m. for an assessment, and he was eating breakfast, no big deal. And an hour later, we came into his room again, and he was eating a snack. An hour after that, his family came in, and he was eating a burrito, and he was talking about ordering lunch. Improper diet can lead to through-the-roof glucose levels. As a diabetic, they should ingest at least 130 grams a day in total carbs, such as fruits, vegetables, grains, and low-fat milk. They should also have 25 to 30 grams of total fiber, and 15 to 20% of their protein should be from their total calories. Their fats in their diet need to be minimized, and also their cholesterol, which should be less than 200 milligrams a day. And they should definitely minimize their total alcohol consumption as well. Exercising is an essential part of diabetes management because it not only decreases your sugars, but it decreases your triglycerides, your LDLs, cholesterol, blood pressure, and improves your circulation. Diabetic patients are encouraged to exercise at least 3 times a week by doing activities such as biking, walking, golfing, running, or playing tennis. To avoid hypoglycemia during exercise, educate your patients on having a 10 to 15 gram carb snack and check their glucose levels every 30 minutes during exercise. Proper foot care is also something we need to educate our patients on. When assessing our patients, we need to check their feet and their lower extremities for cuts, scrapes, and burns for possible neuropathy. In clinical, again, I saw a patient with sores on his leg and his foot that were not healing. And when he was admitted to the ER, his glucose levels were over 300. We can not only do a visual exam, but we can also palpate pulses and take their temperature in both extremities. We need to educate our patients on to walk, make sure they're not barefoot, keep in between their toes dry, to wear supportive shoes that fit well, and notify their healthcare provider if sores on their feet do not heal. Other guidelines to teach our patients would be to get an annual eye exam, to carry an ID band to show they are diabetic, manage their high blood pressure and high cholesterol, and definitely quit smoking. We need to inform them that their insulin needs may increase in times of stress, such as pregnancy or illness. And as nurses, we need to determine our patients' motivation to change their diet, to exercise consistently, to abide with their insulin therapy regimen, and provide as many resources as we can to make sure their diabetes is controlled.